This video reviews the key views essential for fetal cardiac evaluation. We will cover the standard views like four-chamber and outflow tract views, as well as specialized views like the aortic and ductal arches. The four-chamber view is the foundation for assessment. You will identify the four chambers, septa, AV valves, and the cardiac axis. Use Doppler for assessing AV valve regurgitation and inflow patterns, like the EA ratio. Achieving the correct four-chamber view requires precise transducer angulation. The image illustrates the apical, basal, and axial planes and how probe movements achieve the desired key structures. Accurate angulation is critical because small deviations can distort chamber size, obscure valve continuity, or misrepresent great vessel crossover. This can lead to false diagnoses of structural abnormalities. The left ventricular outflow tract, or LVOT view, visualizes the continuity between the interventricular septum and the ascending aorta. Key landmarks include the aortic root arising centrally and mitral aortic continuity. Doppler assesses for obstructions. The right ventricular outflow tract, or RVOT view, evaluates the pulmonary artery origin and its crossover with the aorta. You should identify the pulmonary artery branching into its right and left parts. Doppler confirms antegrade flow through the pulmonary valve. The three-vessel view, or 3VV, compares the caliber and alignment of the pulmonary artery, aorta, and superior vena cava in the upper mediastinum. Look for the V-sign alignment and evaluate flow direction using Doppler to identify narrowing or reversed flow. The three-vessel trachea view, or 3VTV, confirms the normal convergence of the great vessels and their relation to the trachea. The ductus arteriosus and aortic arch should form a V shape, with the trachea positioned to the right of this V. The aortic arch view evaluates the curvature and branching of the aortic arch, which should appear like a, quote, candy cane. You should visualize the head and neck vessels branching off and confirm continuous laminar antegrade flow using Doppler. The ductal arch view evaluates the connection between the pulmonary artery and the descending aorta via the ductus arteriosus, presenting a hockey stick appearance. Doppler confirms normal right-to-left shunting. Systemic and pulmonary venous return views confirm normal venous drainage. Key landmarks include the IVC and SVC entering the right atrium and pulmonary veins entering the left atrium. Doppler helps diagnose obstruction or anomalous connections. The short axis view, or SAX, assesses ventricular symmetry and wall motion. This transverse plane is achieved by rotating the transducer 90 degrees from the long axis view and sweeping through the ventricles. The high short axis view shows the arteries, useful for assessing outflow tracts and valve anatomy. The low short axis view evaluates ventricular function and AV valve morphology. Color Doppler is essential for confirming small defects. Remember the cardiac assessment sweep sequence, which typically flows from the four-chamber view through the LVOT and RVOT, and concludes with the 3VV and 3VTV.